So renal denervation's come a long way. We're going to talk about radiofrequency renal denervation here, which has undergone an evolution, both in its evidence, its technique, and the technology that delivers the procedure. So RF has been recently demonstrated in several sham-controlled trials to be an effective therapy for uncontrolled hypertension. And we've managed to publish several in The Lancet in the last 4 or 5 years, showing significant blood pressure reductions that now we've just shown are sustained out to 3 years. And that's in the presence or absence of drug therapy. So what RDN is doing is it's modulating the communication from the brain to the kidney and the kidney to the brain. So it's a two-way process. And that probably explains why some of the blood pressure lowering that we see doesn't occur immediately. It occurs as a result of modulation of the outflow from the brain sympathetic nervous system control. So what have we learned over the last 7 or 8 years that has helped us to reboot the field? Well, the first is that despite textbooks going back to ancient Egypt, our understanding of renal nerve anatomy has evolved. We now see that renal nerves do not necessarily wind around the artery from its origin to the kidney. So what can happen is they can come from quite a distant position off the aorta and travel towards the renal arteries, arriving in contact with the outside of the renal arteries quite distally along its length. And in this study, we showed that 63% of kidneys had renal nerves that joined the artery beyond the bifurcation. Now, those of you who were in renal denervation at the beginning, you may recall we were taught to just denervate the ostium, the proximal vessel, and the mid-vessel, and to stay away from the bifurcation in case there was any trouble there. In fact, what we've now learned is that in order to get effective denervation covering most of the renal sympathetic nerve architecture, we really do need to be engaging with that area around the bifurcation and in the proximal branches. We also, at the beginning, weren't sure what to do about accessory arteries. So about 1 in 3 of humans will have accessory renal arteries, more than one artery to a kidney or both kidneys. And we've now learned that there's significant innervation to those vessels. And so if we left them out, we may leave behind incomplete denervation and therefore an incomplete blood pressure response. Oops. So this is just a better understanding from pathology prosections of how we apply that information. So renal sympathetic nerves, para-aortic region, and they then give off postsynaptic nerves down and wrap around the bifurcation, which hopefully you can see here. You can see my cursor there. Do you see how the plexus forms around the first order branches of the bifurcation of the renal artery? We also see that there are other structures around that we do not wish to denervate. So the kidney being an important one. So whenever you're delivering this therapy, we stay outside of the parenchymal outline on X-ray, which is very easily seen within a procedure. And we also want to stay away from things like the ureter and from lymph nodes, from ganglia, inferior vena cava, and so on. And all of these structures are very helpfully designed in order to have cooling facilities that mean that we do not deliver significant energy to these, and I'll hopefully be able to demonstrate that to you shortly. So there's now been over 20,000 procedures with radiofrequency using the original Flex and now the spiral device, and more than 7,000 patients published, so we've got a lot of experience. The current device is a nitinol electrode with 4 electrodes at north, south, east, and west. So you put a wire down the vessel, you slide your catheter over it, you pull the wire back, and it springs into this spiral shape that allows us to denervate in a stepped quadrant manner. So we're not doing it in one spot, and therefore risking a problem of stenosis. We're doing it in a step-back fashion with each quadrant at a different point longitudinally. And we've got quite a wide range with this device of 3 to 8 millimeters. So you can see here the image on the left looking down inside an artery, how the device takes shape and how it delivers its energy. And when we started off this field, we saw this thermochromic gel model that was published everywhere that made it look like there were these beautiful symmetrical energy depositions that were occurring around the device. And I think that's not how the real world works. So what the real world looks more like is on the right. So this is a porcine model. And this is a single energy delivery that has occurred around 10 o'clock within this artery. And what we see is that the energy will run through the periadventitial fat until it dissipates or it hits a structure that sucks that energy away. So if it hits a structure like the renal vein, because the renal vein is carrying blood, that blood will take that energy away and dispose of it. So it acts as what we call a heat sink. And so when energy reaches the renal vein, it will stop. Similarly, as it comes to less conductive tissues like lymph nodes, if it gets towards a lymph node, it will then dissipate and the energy will stop at that point. And every other piece of tissue in between the renal arterial wall and the edge of the view has different conductance properties. So what you get is a sort of mushroom cloud effect where you get different depths and different densities of energy delivery and therefore denervation properties to the tissues that lie within. And in this prosection, the red circles are the ones where our renal sympathetic nerves are. And so you can see how to say it denervates in these 4 hemiclovers like you're seeing in the gel model is not the real world. And this is just a cartoon version of it. And we've actually looked at this now to just see what it does. So if you look at RF ablations, the maximum lesion depth in a porcine model at 7 days is about 6.8 millimeters, and the average depth is between 4 and 4.5 millimeters. But the depth doesn't tell the whole story, because if it stops at the renal vein, there are very few renal sympathetic nerves behind the renal vein, so you get quite a short ablation depth there. Whereas on the other side, on the north side here, this is the collapsed renal vein you see at the bottom. On the north side, there are many more renal sympathetic nerves going out deeper, and the energy will conduct in that direction preferentially. So we're getting quite an appropriate lesion depth, but not excessive, that we're worried about other tissues. So what is it about renal sympathetic nerves that makes them well suited to radiofrequency energy? Well, if you look on the left, this is a myelinated peripheral motor axon. So this material around here that looks almost like plastic tubing, this is the myelin sheath that is designed to protect peripheral nerves and to structure them. You do not get that with sympathetic nerves. And so that lack of protective layer and that lack of skeleton is actually helpful to us when we want to ablate these nerves. Because A, we don't have to deliver as much energy to get to the axons inside of it. And B, if there's any attempt to regenerate, there's no skeleton within which to regenerate. Unlike with myelinated nerves, which have a skeleton around the outside of the axons that provide a conduit to channel any attempt at regrowth to allow reconnection. That does not occur with sympathetic nerves. And this is just an example of it with electron microscopy. So what we found in a porcine model is that when you do an ablation lesion, you disconnect the proximal cell body to the distal nerve, and that loss of nourishment and conduction means that the distal nerve atrophies. Now, this isn't atrophy as we think of it in a muscle. What this means is that we have a loss of axonal tissue that's detectable within that downstream tissue, and that downstream nerve becomes useless. It's not something that can be resurrected. Even if somehow there was regrowth of nerve tissue to connect proximal to distal, which is unlikely because there's no structure, what we just get is chaotic proliferation of material from the surrounding structures. It's connecting a proximal cell body to effectively a dead distal nerve. And so we're pretty confident from our analysis of a porcine model that it's unlikely that there'll be regrowth. So once we adequately get the nerves, we think they will stay got. This is an example. So this is in a porcine model where we looked at renal cortical axon density, and what we've done is stained for tyrosine hydroxylase, which is an enzyme involved in the neurotransmitter production at the end of the renal sympathetic nerve. And what we saw is that there's plenty at the beginning, but after denervation, there's no evidence of tyrosine hydroxylase activity or presence in the downstream neurons. And therefore, we think that there's no axonal activity or ability to produce axonal activity there. And then when you look at the output of tyrosine hydroxylase, which is renal norepinephrine, which is the neurotransmitter for renal sympathetic nerves, we see that when you pulp a section of the renal cortex where it's active, and you look at concentration, after a spiral procedure in a porcine model, we see a significant drop in renal norepinephrine concentration that is in keeping with an effective denervation. And we see this at day 7, and we see this in a parallel group of animals at day 180. So it looks like we are able with this technology, particularly when we focus on a distal energy delivery, to denervate the vessel effectively, to denervate it permanently, and then to reduce that sympathetic activity that goes in both directions and will hopefully then produce an immediate response by disconnecting nerve traffic from the brain to the kidney, but then also hopefully a secondary response as the brain remodulates total body sympathetic nervous system activity. So in conclusion, Renal nerve anatomy, our understanding of it has evolved incredibly. Leonardo da Vinci was painting pictures of renal nerve anatomies, but it's actually the fixation of the nerves that has come on that has allowed us to understand better the path of those nerves. And that made us understand that the original technique risked variability. And now we've adapted that to move away from the proximal renal artery to focus more distally at the distal main and around the bifurcation. Spiral uses a shorter energy delivery with this nitinol device than we used to at the beginning. And it's got good safety data now and very controlled energy deliveries out to an average of 4 to 4.5 depth, but it will go out to 6 or 7 millimeters where there is a possibility for the energy to run through the periadventitial tissues, as I described. We have data that we'll hear more about, but the data support the fact, 3-year data from the global registry, that there's not re-innovation. And we see from the preclinical data that re-innovation is unlikely.